All right, so yes, my name is Melissa Fesler. I'm a nurse practitioner and I work at Union Square Medical Associates in San Francisco, where I specialize in the diagnosis and treatment of tick-borne diseases. Today I'm going to be presenting literature that's been published over the last year on Morgellons disease. So unfortunately, I'm going to have to include some of the bad literature that's come out as well. These studies typically dub Morgellons disease as delusional disorders, which require antipsychotics, as well as antidepressant medication, and are generally case studies or reviews and have small sample sizes. Again, I want to remind all of you that Morgellons disease is a dermatologic condition associated with an underlying infection, the most common being that of a spirochetal infection, primarily Borrelia species. Okay, so let's start off with the first bad and ugly paper, and I hope you can bear with me. So our first paper, Morgellons disease Insights into Treatment, comes from our dear friend Dr. Feldman, who was kind enough to join us a few years ago, if you remember. So that's his picture up there. Dr. Feldman is a dermatologist who presented on using good communication during the patient encounter to enhance the physician-patient relationship through active listening and compassion. So the article reviews current treatment options for Morgellons disease and details the author's approach to treatment to provide clinicians with useful pharmacotherapy and adherence techniques when treating patients with Morgellons disease, which includes low-dose antipsychotics and a strong physician-patient relationship. So the authors conducted an online literature search searching for keywords Morgellons disease, psychiatric treatment, infectious. The authors included 8 studies in the paper, 7 were case reports, which again have limitations, and 1 was a retrospective study. I actually highlighted the studies in the table that showed that antibiotics actually do help with treatment, yet that was actually not even mentioned in their paper, even though they presented it. So let's see here. So what Dr. Feldman and his colleagues recommended were low-dose antipsychotics with adjunct therapy, including antibiotics, corticosteroids, and light therapy. They also suggested the need, again, for a strong physician-patient relationship. And so if we move on, this is basically what the study says, is that you need a strong physician-patient relationship in order for patients to take the low-dose antipsychotics. In this funny, it says he amputated the wrong leg. Still, he was a very nice fellow, best not to complain. So I don't want to dwell too much on these bad studies. The take-home message is these studies dub Morgellons disease patients as purely delusional, and they require antipsychotic medications. So let's move on to the next bad study. So our next bad study comes from Weill Cornell Medical College, Department of Dermatology, titled Delusional Infestation versus Morgellons Disease. Let me read to you a small excerpt from the abstract. Let's see here. So infestation with inanimate pathogens, specifically fibers or filaments, has been controversially termed Morgellons disease by the patients themselves, who believe that this is not a psychiatric disease, but rather a new organic condition or skin manifestation of an infection such as Lyme disease. A large-scale study by the Centers for Disease Control and Prevention on patients presenting with Morgellons disease did not find evidence of fibers in the skin, nor an association with any infection, including Lyme disease. Once the diagnosis of delusional infestation is made, the cornerstone of treatment is antipsychotics, although this is often quite challenging as patients are reluctant to take these medications. So unfortunately, this paper concludes Morgellons is a delusional in origin because of the results of that horrible CDC paper that should never have been published. Okay, so To be fair, the study does mention the Charles E. Holman Foundation and Cindy. So let's see here. So ultimately, the authors conclude that all the research that we've done here through the foundation must be incorrect because the CDC did not find Borrelia or Lyme in any of the patients. So here's then their conclusion. So in light of the findings by and conclusions of the CDC's extensive study on Morgellons patients, lack of reproducible evidence at this point of the Morgellons researchers, and overall similarity between patients with Morgellons and delusional infestation, Morgellons disease is best considered delusional infestation and not a distinct condition. Furthermore, reports of Morgellons patients being successfully treated with antipsychotics have been documented in the literature. And then it goes on to say, advocates of Morgellons disease believe their symptoms are caused by Borrelia and other infectious agents, indeed publishing results to that effect, although the largest objective study performed by the CDC did not find this association, concluding that Morgellons disease is best considered a type of delusional infestation with inanimate material. So I guess since the CDC is always right, unfortunately they're the experts, so anything they say must be true despite the good literature out there. And maybe their inability to produce any good literature is due to their preoccupation with the zombie pandemic. It's real. I know, they really have researched it. Yeah, they've. Yeah, oh yeah. But Morgellons is not a real disease, according to them. So the third bad study, again, comes from the Weill Cornell Department of Dermatology. And as you guys can guess, based off the title, the paper discusses how Morgellons disease can be managed by low-dose trifluoroperazine, which is Stelazine. The brand, I believe, has been discontinued in the US. And this is actually the same medication that Dr. Feldman actually recommends at low doses, and he's the one who helped co-author the first paper. So it looks like we're all kind of moving away from ORAP and moving towards the trifluoroperazine. So this is a retrospective study looking at adult patients who presented to the dermatology clinic between 2006 and 2016. So again, one of the common themes we will encounter when reviewing these bad papers is that, first of all, the diagnosis of Morgellons disease is made by visualization of filaments embedded within the skin. Mainstream medicine, doesn't examine the skin, so when they do include these populations of patients presumably with Morgellons, some of them may not even have Morgellons to begin with. So you could see the demographic information in the upper left of the slide in this study, and you could see most patients were Caucasian females. The patients were started again on low-dose trifluoroperazine at bedtime and then titrated as needed, and the response to treatment was measured over time. They also received empathetic counseling as well. What? Oh, it's a type of symptom that you can develop, kind of neurologic presentation. So, 24 patients were included in this study. Only 7 patients returned to their baseline function. Now, baseline function was defined as at least 90% resolution of lesions with no patient-reported distress from the skin. So that seems kind of like a small percentage. Only 29% of patients actually had 90% improvement with their low-dose antipsychotic. 15 patients had 50% improvement, which, well, low-dose antipsychotics can have some antipyretic effect and can also help calm patients down and alleviate some other symptoms. So I guess that could cause 50% improvement. Overall, they found 63% of patients achieved partial or full remission of symptoms, and that trifluoroperazine, which again is similar to ORAP or the pimozide, provided analgesic properties and at low dose had less side effects than pimozide. So here's their tables that they included. It's the next 2 slides. So if you look at the tables, you can see how only 7 of the 24 returned to baseline function. I circled time to baseline function. And on the very right side of the table is the last known disease status. And please note how many people actually had recurrence after initial improvement, many of whom were on the trifluoroperazine. And then this wasn't really discussed in the paper, so I highlighted all the cases of patients who actually had no improvement, and that was kind of their last known disease status. So they might have improved initially, but most of them seem to kind of have relapsed. But still, low-dose antipsychotics work. Okay, so the bad news is you have Lyme disease. The good news is I don't believe in that disease, so you're fine. Just have to throw in some humor because these are very depressing studies that have come out. Okay. So the bad and ugly, number 4. So this study comes from Florida Atlantic University College of Medicine, titled Review of Epidemiology, Clinical Presentation, Diagnosis, and Treatment of Common Primary Psychiatric Causes of Cutaneous Disease. And as you can guess, Morgellons syndrome is what they call it, is included in this study. So this paper ultimately aids dermatologists in how to diagnose and treat cutaneous disease related to psychiatric conditions. So yes, dermatologists are now going to be diagnosing psychiatric conditions, and since they are usually the first specialists to see the patient. Morgellons disease is one of the conditions mentioned in this paper, as I said, and it also includes a guide for dermatologists to use while prescribing atypical antipsychotics, SSRIs, tricyclic antidepressants to treat these conditions. Yep, so dermatologists are now going to be prescribing antipsychotics. Okay, so here the authors provide a little background of, again, Morgellons syndrome is what they call it, and note the patients with Morgellons are typically educated females in their 40s and 50s who have learned about the disease from friends on the internet. And that Morgellons should be considered a subcategory of delusional infestation, or DI. So the dermatologists are instructed not to prescribe antimicrobials, as this may reinforce the patient's disorder. Finally, the conclusion is that dermatologists should feel comfortable prescribing antipsychotics since these patients are reluctant to go to psychiatrists. So you can see what we're up against here. Okay, so here we have the dermatologist telling the patient, you created a new skin disease from scratch. Okay, the bad and the ugly, number 5. Okay, so here we have Ekbom's delusional parasitosis, a systematic review that was published in the Egyptian Journal of Dermatology and Venereology. So Ekbom is another term for delusional parasitosis or delusional infestation, and it's used a lot to be synonymous with Morgellons disease, unfortunately. So in this paper, the authors reviewed the literature to provide the clinician with a perspective on the condition delusional parasitosis, which to them also includes Morgellons disease. Okay. So 223 papers were found with a literature review, but only 38 met their inclusion criteria. Unfortunately, none of the good studies were included in this. So you can see below in Table 3, Morgellons disease was included in their inclusion criteria. So anything they're going to do to talk about Ekboms, they're also going to include anything having to do with Morgellons. Okay, so this table lists the variants, subtypes, and conditions related to delusional parasitosis. Again, I highlighted Morgellons disease, which they describe. It includes delusional infestation with cognitive defects, behavioral changes, and tiredness, and others. And then you can see they have a bunch of other conditions, too, that are written on the left. So the authors say how skin histology is completely normal. That's typically because they don't even examine the skin. So we know that that's just not true to begin with. So again, unfortunately, the authors didn't include any of the good studies in their literature search. This study notes that pimozide is the second-line treatment due to its risk profile of side effects, including extrapyramidal and cardiac toxicity. So again, we're seeing this trend to move away from ORAP. Okay. So in Table 13, the study looks at disorders associated with secondary delusional parasitosis. And it's actually really interesting. They did include infectious disease in this table. Syphilis is actually listed here. And many of you know syphilis is a type of spirochete that's similar to Borrelia. Borrelia, again, is the agent that causes Lyme disease and relapsing fever Borrelia. And then I had to kind of laugh at this. This is the author's step-by-step approach to gain a solid rapport with patients with delusional parasitosis in terms of how they're classifying Morgellons disease syndrome. So I'll just read through a couple of them. But the first consultation encounter is crucial. It's important to look, listen, and be empathetic. Comfort the patient by saying that this condition has been seen, treated before. Reduce patient's agitation, preoccupation. Conduct a thorough skin examination. I don't think very many of them listen to that. That's why I highlighted that one. Yeah, in quotes. So microbiological, parasitological testing should be conducted of the patient's specimens. Examine more specimens in the counseling room and laboratories. Pay attention to recreational drug use. Avoid being misunderstood by patients as supporting their delusions. Acknowledge that the patient's symptoms are real, though delusional. Avoid premature confrontation with patient. Delusional patients who perceive agreement or confrontation are difficult to treat. Within 2 to 3 visits, it is possible to start to explore, discuss the whole illness of the patient. Shakeability of delusion can be estimated at this point of time. Start with non-irritating local therapy for self-induced lesions. For patients with anxiety, depression, antidepressants can be offered. Psychotherapeutic should only be suggested when you gain the patient's trust. Again, there's that trust there. If offered, very few delusional patients would accept an antipsychotic agent, and the list kind of goes on. Even says, be cautious if shared delusion exists among family members. And then further management is joint consultation with psychiatry department. So that's, again, what we're up against here. Oh, yeah. So the authors conclude Morgellons disease and delusional infestation are within the same delusional complex. They note that the prime treatment target is building trust and rapport with the patient to avoid a physician odyssey. I really liked that one. And to prescribe antipsychotics as the first-line treatment. It should be noted the authors report disease recurrence is common, so I guess the antipsychotics don't work that well. That's where they say in the very bottom, it says disease recurrence is common. And the whole physician odyssey, that's why I put that picture up there. It's a known phenomenon. I Googled it and I had this come up. Yeah, so the physician odyssey. So I added this little funny, and again, I found the tick, the bullseye, did 3 weeks of antibiotics and still got the disease. What disease? And I just had to throw this in. This is kind of the end of all the bad, but thank you, Cindy. So our dear friend, Dr. Koo, I don't know how many of you are familiar with him. He specializes in Morgellons disease. So Dr. Koo and 2 dermatology fellows at UCSF have published the book entitled Morgellons Disease, A Survival Guide for Dermatology Providers. So you can get it for $75 on Amazon Prime. If any of you are interested, please don't buy it. The management of delusions of parasitosis, DOP, also called Morgellons disease, among the lay public, leads to some of the most difficult and stressful patient encounters in the practice of dermatology. Most dermatology providers dread having to deal with one of those patients. This is entirely understandable. Dermatologists and other dermatology providers have little training on how to connect with these types of patients and in the use of pharmacotherapy for this condition. If I read it, I'll be waiting for it to come out free on Kindle. You got it. What? No. I think there's one review when I last looked and it had 5 stars, but it was a bad review. They gave it 5 stars though. Basically, they were amazed at how bad it was. Okay, here's a little funny here. Well, I think we've nailed it, Lyme disease. Oh, and I can't see you anymore. Okay, so I'm putting this first one kind of as a question mark. At first, these authors have published some bad literature on Morgellons disease, but their most recent study is pretty promising. It actually comes out of China. So I did eventually move it into the good category. They actually cite a lot of Marianne Middlevine's research and determine that further investigation is needed into looking into Morgellons disease. So, the title is Reframing Delusional Infestation, Perspectives, and Unresolved Puzzles. The abstract states Morgellons disease, characterized by the presence of cutaneous filaments projected from or embedded in skin, is also a polemic issue because of its relationship with spirochetal infection. This review discusses, 1, the relationship of real or sham infestation with DI or MD, behavior alterations such as self-inflicted trauma, neuroimaging abnormalities and disturbances in neurotransmitter systems, and impaired insight in patient with the disease. They conclude further studies are warranted. At least the study does go into discussing the relationship with Morgellons disease and a spirochetal infection. So they produced an atlas of alleged pathogens in patients with delusional infestation. So they have the inanimate group and the animate group. So some patients really do have a true infestation, others don't, and they kind of go into discussing this a little bit, and that's important for the clinician to consider when making a diagnosis. Okay, so here, again, they describe Morgellons disease characterized as embedded or protruding filaments in skin lesions. It was once considered as a variation of DI or delusional infestation by some researchers. However, other researchers have claimed an infectious process underlying this disease. The presentation of specimen, which is further confirmed as cutaneous filaments, may not be delusional in some cases. They reported positive tests of Borrelia spirochetes in patients with Morgellons disease. In these studies, the researchers found that patients with Morgellons disease shared similar systematic symptoms such as skin irritation, fatigue, joint pain, cardiac complications, and cognitive deficits to those with tick-borne illnesses, for example, Lyme disease. They reported that major components of Morgellons disease cutaneous filaments were keratin and collagen, which were produced by keratinocytes and fibroblasts. The formation of these filaments could be resulted from skin proliferation and underlying infectious process. Treatment of Morgellons disease patients seems to be more challenging than those with delusional infestation patients or DI patients. Therefore, Morgellons seems more likely to be a discrete entity rather than a variation of delusional infestation. So, yay. So, good job, China. Okay, so the authors conclude, again, Morgellons disease is not a subtype of delusional infestation, and its interplay with spirochetal infection needs further investigation. You can see a picture there of Borrelia burgdorferi. What I found really surprising was that the authors actually state that the presentation of a specimen is not delusional behavior. Typically, that's just classified as matchbox sign when you bring anything in, so that was really surprising that they said that. In summary, if the physician cannot differentiate between a true observation delusion overhauled ideas or overvalued ideas, and they should not immediately make a diagnosis of delusional mental illness. Okay, so let's move on to the second good one. So Dr. Shaw actually spoke about this paper earlier. So Middleveen, Cruz, Fesler, Stricker, and Shaw published detection of tick-borne infection in Morgellons disease patients by serological and molecular techniques. 30 patients with Morgellons disease were tested for tick-borne disease. And I'm not going to go too much into this just because Dr. Shaw presented on this earlier. What the authors found is that 90% of the cohort tested positive for exposure or infection with Borrelia, which is the agent that causes Lyme disease and relapsing fever Borrelia. Okay. And so again, Dr. Shaw presented on that. So we're going to move on to the next good study. Okay, the next paper comes from Fesler, Middleveen, and Stricker, and it's titled Clinical Evaluation of Morgellons Disease in a Cohort of North American Patients. This study was conducted using test results from IGeneX on 60 Morgellons patients from our practice in San Francisco. Of those 60 patients, 100% tested positive for Lyme disease. Here we go. 100% tested positive for Lyme disease. 50% tested positive for Babesia duncani. 12% tested positive for Babesia microti, 25% tested positive for Bartonella and Rickettsia species, 15% Ehrlichia, 10% Anaplasma, and 12% also had Helicobacter pylori. Okay, and then you can see most patients on table number 5 on the right side actually had between 1 and 2 co-infections, and those are just the other bacteria you can also have aside from Lyme disease. 78% of those patients presented to the clinic with late disseminated Morgellons disease. Basically, that means that they've had the condition longer than 3 to 6 months, and it's over multiple parts of the body. You can also see in Table 3 the symptoms that were noted in Morgellons disease patients. 93% had musculoskeletal symptoms, and then from there it goes down: fatigue, insomnia, cognitive impairment, depression, hypothyroidism, anxiety, and neuropathy. Okay. There was a 3-to-1 female to male ratio, and women tended to be older. The natural killer cells, so on the right side, the natural killer cells are kind of a marker of Lyme disease. And the C4a is a non-specific marker of inflammation. And so patients tended to have kind of lower CD57 test results, and kind of across the board, they had both low and high C4a. All right. So our next good study, here we go. So this paper comes from Middleveen, Soppy, Burke, Flush, Franco, Fesler, and Stricker, and is titled Persistent Borrelia Infection in Patients with Ongoing Symptoms of Lyme Disease. In this study, cultures of body fluid and tissues was performed on 12 patients who had persistent symptoms of Lyme disease, who were on antibiotics, or who had previously been treated with antibiotics. And several of the patients included in this study actually had Morgellons disease, and that's why I'm mentioning this paper. So you could see here, so these were the clinical characteristics of the study patients. In case 1, 2, and 12, those patients had Morgellons disease. You could see the age and gender. So those patients were all females, and they were between 46 and 54. Only one of them actually had an EM rash, or kind of like a bullseye rash from a tick bite. They all had lesions of Morgellons disease. Only one of them, case 12, was actually seroreactive for Lyme disease. 2 of them had co-infections, and 1 of them had been on antibiotics before. That's case number 1. So this table summarizes the microscopy results from the patient's culture samples. You could see spirochetes were actually detected in all patients with Morgellons disease. So again, the authors, they found positive Borrelia cultures from all 3 of the subjects with Morgellons disease. And cultures used to be the kind of the gold standard for diagnostics, because if you can grow the bacteria, it's definitely there. So here you can see some of the pictures of the spirochetes and some of the fibers or filaments embedded within the Morgellons skin. So the top left image, that's dark field microscopy of a blood culture showing a live spirochete. The bottom left is a Dieterle stain of a culture fluid from case 10 showing a live spirochete. The top right is a Borrelia immunostain of culture from case 9 showing a live spirochete. And the bottom right, there you have that typical dermal filament of a patient with Morgellons disease. So you can see kind of the embedded colorful filament. Okay. So all your tests for Lyme came back negative. Just adding that one in. Okay, so we're moving on to the next good study. And so basically the take-home message is that, Borrelia has been identified in a majority of patients with Morgellons disease. So again, the treatment of Morgellons disease is treating the underlying infection, which at this point keeps pointing to a spirochetal infection or Borrelia species. Okay. All right, so this paper by Middleveen, Fesler, Stricker, titled History of Morgellons Disease from Delusion to Definition, provides a thorough history of Morgellons disease, diagnosis of Morgellons, reviews the controversy of Morgellons disease, and discusses how to diagnose delusional disorders, provides evidence of an infectious etiology related to Morgellons disease, and discusses treatment. How many of you have read this paper yet? Okay, well, if you haven't, I definitely suggest reading it because it goes into everything you possibly would want to know about Morgellons disease. So here's just a brief excerpt from the beginning of the history part of the paper. So the name Morgellons, pronounced with either a hard or soft G, comes from a letter written in 1674 by Sir Thomas Browne, an English physician. The letter contains a brief description of a skin disease in French children. Hairs which have most amused me have not been in the face or head, but on the back, and not in men but children, as long ago observed in that endemial distemper of little children in Languedoc, called the Morgellons, wherein they critically break out with harsh hairs on their back, which takes off the unquiet symptoms of the disease and delivers them from coughs and convulsions. So Browne's description of the Morgellons and other historical accounts of similar maladies date from 1544 to 1884 and were found in Browne's library 1935 by Kellett, who then summarized and discussed them. So the history paper really goes into a really pretty in-depth history of all of this. It also includes a lot of the themes that we see that are kind of rampant throughout the bad papers that were discussed. So I'll go over that a little bit so you guys know how to kind of look out for the bad stuff. So Morgellons disease is a delusional disorder. Morgellons is a variation of DOP, DP, or DI. Morgellons is defined as the fixed, unshakable belief, despite lack of medical evidence, of being infested with microscopic organisms or inanimate objects. The presentation of specimens in and out of a container, whether it be matchbox, plastic bag, paper, pill container, photographic image, ... Patients with MD tend to have psychiatric comorbidities. MD is a mass delusional mental illness afflicting primarily middle-aged Caucasian females. Delusions of infestation are spread from person to person and transmitted by the internet. Antipsychotic drugs are the treatment of choice for Morgellons disease. And then it goes on. I'll just read a few more. Electroconvulsive therapy is an acceptable treatment for Morgellons disease. Establishing rapport to gain confidence and trust helps convince patients to take antipsychotic drugs. Using the word Morgellons in dialogue with patients can help establish rapport and trust. It is acceptable for dermatologists to diagnose delusional disorder and prescribe antipsychotic medication. We just saw some of the guidelines that are now published out there for that. Use of deceptive dialogue and strategies aimed at convincing patients to take antipsychotic drugs is justifiable in practice. And if a patient's friend or family member also observe a subject's dermatological lesions and believe the evidence, then they too are considered to share the delusional belief, and the delusion is considered to have been transmitted from one individual to another. The belief shared by two people that there are organisms present in the skin is called folie deux, madness of two, folie trois, folie à quatre, and folie cinq are shared beliefs by 3, 4, or 5 people respectively. And shared beliefs in a family is folie à famille. So these are the common themes that you see in the bad papers. Okay. So I wanted to just read part of the early history section of the Morgellons history paper. So in modern times, spirochetal infection was implicated as an etiologic factor for Morgellons disease as early as 2006, when William Harvey, a former medical director of a laboratory contracted to work for NASA, explained to a medical reporter, Chico Harlan, with the Pittsburgh Post-Gazette, that he had been studying a group of 70 Morgellons disease patients, all of whom were infected with Borrelia, the causative agent of Lyme disease. Savely et al. In 2006 reported that the principal author, nurse practitioner, Virginia Savely, had seen 80 patients in her practice who fit the criteria for Morgellons disease, and all but one of these patients had tested positive for Lyme disease. All right, so here's a wonderful picture here of an embedded cutaneous blue and white filament. So you can kind of see that embedded within the skin. This is typically what we see of patients who present at our practice, and this is again at magnification 50 times. And these are all included in the history paper as well. Here's a longitudinal section of a filament originating in the basal layer of the epidermis adjacent to the dermis. So again, these are fibers originating from skin cells. So these are not self-implanted. And this is actually at magnification 400. Here are filaments remaining embedded in deep layers of the skin after removal of a callus. You can see they're really beautiful blue fibers, and this is at magnification 100. And so the upper left is a filamentous follicular cast. So those are white filaments originating on the outer follicular sheath and are growing in a collated manner. And we do see a lot of patients who present samples of these. So this is all originating from the skin again, so these aren't sham artifacts. So, and then on the right, you could see pili multigemini, which is a common finding in Morgellons disease patients where you have multiple hairs that originate from the same bulb. So 66, let's see. Here we have, so the top is a thickened follicule, a follicular cast growing inwards, along with clear inward growing hair. So you could see kind of that center long part is actually a hair that's growing down into the dermis, and that oftentimes causes a lot of pain with patients, and that's why sometimes removing that top layer actually can provide some relief. The lower bottom image is actually a bovine digital dermatitis. And bovine digital dermatitis is caused by a treponeme infection. So the treponemes and Borrelia are both types of spirochetes. So bovine digital dermatitis, so it occurs in cattle, and they also get these weird filamentous growths of their hooves, and it's quite common in Europe actually, and it's a huge problem. So there does seem to be a kind of an association or similarity. Okay, and so here, so this is kind of the ending of the paper, and I'm going to kind of end on this part. So it's important to note that etiology of Morgellons disease is believed to be multifactorial: genetics, endocrine influences, immune status, presence of other infections, including tick-borne infections. You can see the left of the slide shows a single spirochete from a specimen obtained from a patient with Morgellons disease at 100 times magnification. All right, so here are the bad references. and then the good references. Okay, and then thank you all for your time, and thank you to Cindy for having me here today. And I'll leave it on this.